Hello, and welcome to our very first episode of Designing Care on Air, where we explore the world of nursing and healthcare design. I'm Elizabeth Johnson from Montana State University Mark and Robin Jones College of Nursing. And in today's episode, we are joined in discussion by someone who has decades of experience in the healthcare profession, which includes direct patient care, healthcare operations, nursing administration, and executive leadership within inpatient and ambulatory settings. It's a pleasure to welcome Julie Dumser, who's a senior manager and business consultant with EY Health Transformation. Julie, thanks for joining us today.
Absolutely, Liz. I'm thrilled to be a part of this.
Thank you. Well, just to kick off, if you don't mind just describing a bit about yourself, your background education, and your current role within the healthcare and facility design industry.
Absolutely. So, ever since I was a little girl, my mother was a nurse and I wanted to follow in those footsteps. So, like many of us, right out of high school, I went to nursing school. I live in Indiana, a small town, not nearly as rural as many, but grew up on a farm. And I only received initially my Associate of Arts degree in nursing because, we all sit for the same exam, regardless of BSN versus associate, or I think there was even another opportunity in the mix at the time. Anyway, so I graduated from nursing school and I went straight to the Children's Hospital in Indiana, and I loved it. I spent 13 years there and I did every kind of position that you could think of, but it was always my actual care was of surgical patients who we shared our staff with the adult hospital. So at times we would trade if one or the other hospital had a number of people calling sick or had to be out for meetings that were really important, things like that. So obviously the expertise was in the child care, but also exposed to the adult practice. And what caused me to leave was a surgeon that I worked very, very closely with accepted a position in Seattle, and he left the hospital, and I was pretty devastated about it. So I ended up spending some time thinking and said, if he can leave, I can too. So I explored an opportunity in the ambulatory world, and I ended up taking a director of nursing role at a small surgery center. And that was the beginning, if you will, of how design came to me, because I spent 2 years at this little bitty surgery center just learning how to have 24/7 responsibility for not only patient care, but an entity. And then another surgery center was under construction. And we usually advise that for a newly put up practice that's going to be a surgery center, that you try to hire the director of nursing at about a 6-month before opening date. So I interviewed and got the job. And of course, as I mentioned, the facility was under construction. So once you are on board, now you are participating in the owner, architect, contractor meetings to understand, what are they putting, what's my flow intended to look like for both patients and staff and providers. And you start to get to have input when you think about efficiencies and where they should be. And as you choose where they've already designed where pre-op and recovery are going to be and where the ORs are going to be. So you get to think about, how am I going to staff that? And again, I loved it. I've been very fortunate my entire life to always love what I'm doing. About 4 years into that job, which was a very successful surgery center, the contractor called me up and said, I'd like to meet with you, and ended up telling me that he was building a lot of these around the country. And they discovered that the link they were missing was the clinical operational activation. So he wanted to know if I would join their firm and perform that activity with physicians and or hospitals. And I did. So all of a sudden, I am now learning how to read blueprints and how to more effectively uh, discuss with the clients what I believe this patient flow should look like. Another side of that, of course, is an introduction to big data dump, because in order to understand how many operating rooms are necessary, you need to know how many surgeons are coming, how many cases they plan to bring, and what are those cases. Because again, ambulatory, the expectation, I come in, I go home. And as we as nurses know, that the acuity of a patient is determined by anesthesia when they rate them. So all of that goes into the planning. And I got to travel the country at this point, setting up surgery centers. And through that, I was approached by a very large corporation who also said we are lacking in that skill set. And through there, I met a good friend who I've now known for over 12 years, who said to me, I'm going to be taking a position with an architect and engineering firm, and we're going to strategically need to hire at 1 year a perioperative specialist. And I said I was very interested. So at that 1 year mark, they did call me, and I went to the architect and engineering firm and have been doing that I did that for 8 years before I just left this year to go to EY and bring that same skill set.
That's incredible. Based on your experience, how through your work with architecture and engineering, do you then find yourself advocating to bringing in nursing? And if so, how do you do that?
We are consistent and constant advocates for bringing in nursing. If any of you listening are old enough to have experienced the effects of the recession that we experienced in 2008 with the housing crisis, a lot of what happened during that time was any nursing resources that were working with architect and engineering firms were probably one of the first to be let go, because it's viewed as an augment to the actual work of drawing the design and bringing it to fruition and having it permitted and such and so forth. So all of the larger architect and engineering firms have brought that practice back and have nurses on their staff with a variety of expertise. Again, mine being perioperative, but another place that is very popular for nurses in design is the ED. And then, of course, the inpatient care, which ranges from a med-surg unit all the way up through ICU. And those are some of the very key positions to have in a number of ways. First is that the nurse understands the language being used at any of the user group meetings with the hospital or the provider groups. And secondly, when it's advantageous for the A&E, and that means architecture and engineering, for the A&E firms to have a resource that their younger architects can ask questions of before they go back to the client. So many times it saves a phone call or a misunderstanding, because your nurse on staff can help you understand why this particular thing that your client wants to focus on doesn't seem important to you. But if it's related to infection control or something that is about the Joint Commission or the HFAP accreditation bodies, the nurses innately know that. And in my world, we continue to always be updated on that, because the CMS guidelines, and we all know as nurses and practitioners that these accrediting bodies are very, very, very important to hospitals in terms of remuneration. So you don't want to really set up anything that is not going to be effective in meeting those guidelines. And that right there, that in and of itself is why the nurses are so valuable to the design process.
Absolutely. And I think most nurses would agree the built environment not only affects patient care, but also affects their work too, and their wellness. I've seen through our courses and our students here. that they've become really engaged and excited about built environment once introduced. As you made the jump from bedside nursing to the architect and engineering side, what types of training or resources did you kind of lean on during that transitive process to learn the language, to understand the culture?
I love that you asked that question. Individually, I am somebody who is, I try to sometimes, I describe myself as a research junkie. And I know that, you're an expert at it. I just sort of play around. But through that, I spent my own time looking at any kind of article that had been written about nurses in the design process. And as you're reading, you pick up the organizations that the articles reference. For instance, they would talk about FGI, which is the Federal Guidelines Institute. So I start researching, I go out to the FGI site, and as with many of these expert entities, you can retrieve a lot of information without being a member or without having the credentials to have to need that resource in your back pocket. So I started reading these FGI guidelines, which talk very, very specifically about what some minimum recommendations are in the design of space. And the word recommendation is really critical because, as I referenced earlier, the people who give you the blessing are CMS and your Department of Health and your accrediting body. They will lean towards these guidelines, which are a recommendation, but they are the final say in whether or not what you have on paper will meet their requirements. And then, of course, they get to come back again once you have opened your doors and do a survey to make sure that you can provide safe patient care. There are so many organizations that publish publicly. For instance, the HCAP scores we know are about the consumer and their experience while they're an inpatient. So when you look at an HCAP score, you want to say, how does that relate to a design? And so let's take, for instance, the one that asks if the environment was quiet at night or quiet when you needed to sleep. In the design world, that says, what do I do with either my finishes, like flooring and walls and ceiling, that may augment the ability for the environment to be quieter? And so, go back to answer your question, it was through just beginning to read of stories of other nurses and how they had made that leap and understanding, writing down what resources did they use. And once you start that, it becomes a big web and you begin to learn kind of what the guiding principles are. And then number two, of course, is you absolutely lean on your coworkers at the architect and engineering firm to understand from them, how might I help you? What do I need to know that relates directly? And what resource would you guide me towards to make sure I understand what you do aligned with what I want to accomplish?
Yeah, and I think the biggest thing too is that we bring to the table as nurses not only our skill sets and our perceptions, but that we're also very skilled communicators.
Very.
Talking to a lot of different disciplines all the time at the drop of a hat, right?
At the drop of a hat. That's so true.
So when I hear about nurses in the design process, I think that's one of the biggest wins that I hear is this effective communication and accommodation across different disciplines that we then translate. We can learn the language, but also be able to adapt to others and they adapt to us. So when we talk about communication as far as these resources, what tools have you found are used to facilitate effective communication across team members that you work with?
A number of them, Elizabeth. And as a practicing nurse in all of that training and working in an academic medical center, we were afforded the opportunity to go to formal classes to learn about communication techniques. So as I went to as many of those things as I could, and then began making sure that my staff also had those opportunities. And I've been in the business a long, long time. So I've seen what that progression looks like. And bringing it to the design firm was not challenging, but actually really engaging. I asked about a year into it, because for those of you who have not taken a job yet in the field, or have one and are moving to a different location or different professional type of job, it takes about a year before you absolutely really know what decisions can you make on your own and they're going to be fine. And you pretty much know where to get anything that you need. So at about a year, I had a conversation with an architect and I said, tell me how you did this before we were here. And this was very insightful. He said, we were called in to a meeting, and it was usually the C-suite or the facilities director, the facilities department. And we would sit down at a table and they would tell us, they would describe what they needed us to build. And that's what we did. And he said it was a very closed environment. It clearly was someone's making these decisions and then taking them to the users to say, here's what you're going to get. And I said, so can you describe to me now how you believe that us being a part of this has improved or not the communication that occurs? And he said, it has been absolutely night and day. Because now we come in and we start to discuss with whomever the groups are, what is it that you need? Can we talk through what your challenges are so that we can then come up with ideas about, well, here's what we think just based upon what we've heard. However, it will be very, very important for us to interview all of these key users, which are, again, depending on what your project is, but you want to talk to even, you want to talk to housekeeping, you want to talk to dietary, quality control, risk management, of course, the nursing staff, the CNA staff. You want to talk with a couple physicians so that you have an absolutely well-rounded concept of what the need is based on their patient population and where they work right now, what needs to occur here in the design. So it's gone from listening to a group of people tell an architect what to draw to now taking a step back, which is really truly is a 2 to 3 month effort to make sure that you hear all the voices necessary before you draw, before you put pen to paper for a plan. And that type of communication affords the institution's staff to be part of the process and to celebrate at the day and time when those things open and they have new, efficient pathways of care providing the ultimate in patient safety. And I will say that bar none, Elizabeth, a guiding principle behind all of these is always patient safety. And so for those institutions that have patient and family councils, we also like to meet with them and say, tell us your experiences with the hospital and talk through areas that were good for you, things that maybe didn't meet your expectation, so that we are not just hearing the providers who work there, but we're also hearing the patients who come.
I am so glad to hear that, because a lot of what we look at as far as safety includes how do we do that on a dime with budget constraints? How do we also bring in our cultural context? So the people we serve as well as where we reside and what resources we have in our immediate realm. When you're working on patient safety, when you're at that point in the design process, you're bringing in these voices and you know your project setting. How do you prepare for that process? That first meeting, if there's a cultural consideration, the project setting, or if there's going to be a minimal budget.
And that's pretty normal, the minimal budget. And I will say that it's been really enjoyable, however challenging, again, given the environment right now and the way that the prices have significantly increased in everything that we access, the fuel and the groceries. However, on the same side, when you are talking with a client who's needing to build, they need a new build or they need a renovation, the costs are extremely different from what they were 3 years ago, as in vastly accelerated. And so the approach that will always occur is the typical wants versus needs. So as you're having these initial conversations and believe that you have heard your customer on all their needs, including and especially culturally what will work, you then come up with a draft design. And during this, you will have the experts in that space. They will have an estimate of what that cost might be. So if we're looking at an extreme deficit, as in something in $10 million between what you thought it was going to be and what it's estimated to be, we're going to go back to that key driver of patient safety. And we're going to go back to what will the Department of Health and CMS approve for us? And on the wants and needs list, what can be eliminated that does not compromise patient safety? And you can drastically cut down a list of desired items using that approach to see where does my price come out now, given that I can provide safe care, but I can't have a lot of these things that I want. And sometimes it's happened where you have to reduce the size of what you're going to offer because there's just not room to meet the things that are an absolute requirement right now to provide safe care with, oh, I also wanted to move, I thought we could move this clinic over there too, but I can't because I absolutely must and have to spend the dollars to implement XYZ. So it's definitely a trade-off. It's always great when you don't have to be so hard or so tough, but right now that's the environment. The dollars are very hard to come by, and making sure that you construct and design the things that will provide safe care. And there are always the entry level, the middle of the road, and the Taj Mahal as choices. So that's kind of the hard part, but we present it in a way that the clients are individually kind of voting, or we do activities where we give them a group of dots, the sticky dots, and there's 10 of them. Your sticky dots represent $100. Where do you want to spend your money? So each of these areas will be spelled out. You'll take your own, and this is absolutely just your opinion. And if there's an item up there that you want more than anything else on the whole list, you can put your entire $100 on there. But you could also divide it up into $50 on this one and $50 on that one. And as the rules of this activity are laid out, people know that at the end of this, we're going to be seeing where all the dots are at. And those are going to be the priorities to come out and keep in the design process. This is another thing that's really important. In the very beginning, we have the clients create the guiding principle for the project. And then we bring those to every single meeting so that they are ingrained in every user that these are the outcomes that you want when this project is done. because they will and have, without a doubt, 100% of the time, there's a need to respond back to those guiding principles when making a tough decision about what to keep and what you can't afford.
Absolutely. I think those are the hardest things to do, is to make sure you don't have that scope creep, especially over years and years of development. Things are definitely changing. The context may be changing now from year to year. So, have you seen any trends or patterns about these types of priorities that people are selecting on your projects?
We have, I'll bring up two of them that we see a lot. One of them is the centralized versus the decentralized model of care for nursing. And for those who may not know what it is, many, many years ago, and you go in hospitals now, and there's what you call the nurse's station. And that's the hub of communication. And everybody, all the caregivers are trying to find space in that nurse's station to sit down and work at their computer or to have a conversation with another care provider about a patient. And that's the centralized method. The decentralized is the type where you will see a mini workstation that's located throughout the hallway close to the patient rooms. There could be one between two rooms, or there could be one on the med-surg floor. You might find one station that serves 4 patient rooms. And it is still, with the research that's been done, it's a 50-50 mix between nurses who have had post-occupancy surveys about how well do they like the decentralized, because that's the newer one that was introduced. And so what has happened and what is a trend is to put in both, so that when you want to be part of that group that's congregated in the traditional nurses station, you can go in there. But if you have a patient that's more critical, or you need a more quiet space to work, the decentralized method is great for that. And so it's turned out that clients have began to ask for both. And it does mean that you can reduce now the size of the centralized nurses station, because it no longer has to hold 40 people. It can be designed to hold 20, because there are all these other touchdown spaces that any provider could sit at to utilize a laptop if necessary. And the other one is, again, completely about nurses, if you will. And someone is always saying, well, what's the biggest nurse satisfier? Well, the biggest nurse satisfier is give me some more time so that I can pay attention to my patient. And we can't provide more time, but you can inadvertently. So one thing that has stuck with me for a very long time is the nurses who said, I don't really care as much if I have to walk an extra 20 steps to get what I need, if what I need is in its place. So a trend has been, and it's been approved by departments of health in numerous states, for there to be, if you will, think about a big Walmart or a big Meijer. And so the supply room really can also hold everything you need, including a specified area for medication prep, so that the nurse only has to go to one area to collect anything you might really need for that patient care. However, the side piece of that is that supply chain must be intimately involved in this design process so that their restocking is consistent and meets the expectations of the nurses who say, I'm not going to care so much about how far I go if the item I need is there.
I think that's one of the things that we hear from our nurses here in Montana, is sometimes there's either not organization among supply management racks, or that they feel congested or bumped if it's too small. Like they're trying to prep a medication in a room or try to do a pull while somebody else is trying to get something else behind them. I can see where nursing voice factors in, as far as you may be walking a little bit farther, but at least there's the space that you need and it's organized. There's expectation present. We appreciate your time today, Julie. And just as a finishing comment, is there a piece of advice or words of wisdom that you can provide our nursing and engineering students listening in who are studying systems thinking and healthcare design?
That's a great way to close. Thank you for the opportunity to share here. I have been an advocate of nursing since day one, and I want to stress to your students that there is never a question that they shouldn't be asking. Once you enter the work world out there, just be a sponge. Ask all the time about anything that you do or don't understand. Ask for a second opinion. Say, I really enjoy XYZ. What do you think about that? So that you can hear those who have a differing opinion, because knowing it helps you approach your clientele, your coworkers, with a sense of knowing that someone may not view the world the same way you do or the item that you do. And on the engineering side, I have loved, as much as I have learned over the years from my engineers. Again, if I go back to my specific part of being a perioperative nurse, so the air exchange in the OR is absolutely critical to what we do. And watching where that has come over the years in the design process and exploring that with the engineering staff has really led me to be able to have conversations with nurses in spaces where the engineer might not be in the room, but I'm confident that what I'm saying is equating to those same principles that the engineers would have. So one of my coworkers came up with kind of a acronym, not an acronym, but a new word. And I don't know if any of you've heard it before, but he calls it surgeoneering, because the surgeons and the engineers really work together these days to also provide the safest type of care. And it's been wonderful to actually see those entities come together and understand what you do versus what I do. We're both after the same goal. And listening, being a part of those conversations, just continues to help you grow in your own intellectual knowledge about this design world.
I think you touched on it beautifully, that through cross-functional communication, through working together, we really do have a common goal. Different voices, common goal, and stay curious to get to patient safety. Thank you so much for your time today. And thank you, listeners of Designing Care on Air, where we've learned today how critical the nursing voice can be to accommodate and tackle these design challenges, whatever the context. And at the end of the day, while we may have this diversification of voices, we truly have a common goal to have an optimal experience for our providers and facilitate safe patient care. This is Elizabeth Johnson for Designing Care on Air, and we'll see you next time.